but just wanted to let you know you'll get a little notification that we are recording. And Kristen, you want to quickly get us started?
Yeah, good morning, everybody. It's great to see you all. Thanks for joining us bright and early. We are here today to do a brief training on the behavioral health data collection protocol that we will be using with both inpatient and emergency departments over the next month or so. And I wanted to note right up front that this training is focused on both the emergency department and inpatient protocols. They have the same flow, so we're going to talk about them simultaneously, but we do want you to know that you're in the right place, regardless of which type of facility you're joining us from today. This morning, you're going to hear from three of us. My colleague, Alicia Simon from the Minnesota Department of Health. The Minnesota Department of Health is leading this study. And we're excited to have Alicia here today. And then my colleague Mia Mua and I'm Kristen Dillon. We will be talking to you about the nuts and bolts of this specific data collection period today. So for our agenda, we're going to talk about the purpose of the study. We're going the technical assistance that will be available throughout the study. And we're going to show you the online tool where you will be entering data so you can see how it works. We are also going to go through the data collection definitions for what it means, the reasons for discharge or transfer delay, and then we're going to talk briefly about analysis and reporting. I want to let you know that in addition to this training, there will also be written protocols for both the emergency department and inpatient sides of the study that you can refer back to. So you don't need to memorize everything that we're talking about today. We just want to give you an opportunity to hear from us and ask questions today. So I'm going to hand it over to Alicia.
Thanks, Kristen. So as Kristen said, my name is Alicia Simon. I'm the Health Economics Program at the Minnesota Department of Health. And just going to give you kind of a broad overview of the study. This is being led by the Minnesota Department of Health, but it's based on similar studies that some of your hospitals may have participated in that were done in Minnesota in 2016 and 2019. So the purpose of the study is to really better understand both the volume and the reasons for behavioral health discharge delays in both inpatient and emergency departments. We know that there is a problem with discharge delays, but what's really important about this study is it really helps us figure out where people are trying to go that they can't get to. So really quantifying those service needs outside of hospitals. And this will help us both inform policy and practice within the mental health infrastructure in Minnesota. But then also the legislature in 2022 passed an exception to the hospital moratorium for adding more inpatient mental health days. And part of our responsibility under that was to understand sort of the mental health landscape and find out if kind of opening up inpatient mental health beds is going to sort of solve the problem between 2022 and 2027. And so this study gives us a really good sense of what is it like just before we maybe start to add some of those mental health beds, but also, again, pointing out that it's not just the inpatient or the hospital side. So the way we started the study was we worked with a tool that was previously created by Wilder Research and the Minnesota Hospital Association. The MDH project team made some revisions, and as part of that process, we gathered input from staff and leaders from several hospitals, as well as some community behavioral health providers, and that was really helpful, especially for the reasons for delayed discharge. And now I'm going to pass it to Mia to talk about the data collection process.
All right, thanks, Alicia. As she mentioned, my name is Mia, and I'll take you through the data collection process. If you go next, please. So while the research is available to provide technical assistance throughout the study, so any questions about data collection, including questions about definitions, how to use the forms, or submitting data should be directed to me. I am typically available between 8 a.m. and 4:30 p.m. Central Time, Monday through Friday. and my contact information will be available at the end of this presentation as well to you. Next slide. And to go over eligibility criteria, this tool should be used to track all behavioral health patients in a patient care and emergency departments during your hospital's chosen 2-week period for data collection between the launch date of September 5th and October 20th, even if they were admitted prior to September 5th, who meet the eligibility criteria to be discharged or transferred to a different care setting, but they continue to stay in your facility. So hospitals with inpatient psychiatry units should be tracking patients admitted to inpatient psychiatry, excluding partial hospitalization patients. Um, and hospitals that do not have inpatient psychiatry units should be tracking all behavioral health patients admitted to inpatient units. And some hospitals may choose to track patients in both their inpatient psychiatry units and behavioral health patients in their medical units. And for the purposes of the study, a delay in the emergency department starts if a behavioral health patient is still in the emergency department 4 hours after a disposition decision has been made. And then it is up to each hospital to determine when a patient would be eligible for a discharge in the study. Next slide. And so this form gathers the reasons for preventing a patient from moving to a different care setting for the behavioral health issues. So it will be tracking admission characteristics such as like where they're admitted from or how they arrived to the ED, admission dates to inpatient care, and the nature of admission, whether it was involuntary or voluntary. It'll be tracking patient characteristics as well as the state or county of residence, age range, gender identity, race and ethnicity, or insurance coverage. It'll be asking for the date and time of when the disposition decision was for the ED admissions was made, and to make a note that the clock does start at about 4 hours.
Living like this happen given the staffing struggle here right now.
It will also be asking for the reason for potentially avoidable days under the umbrellas of internal staff delays, core service agency delays, space in safe setting not being available, or patient or family delays. This form will also be asking to identify patient characteristics that are associated with the delay, such as homelessness, substance use, or cognitive impairment. If the patient does have the characteristic, but it's not directly related to the delay, we ask you to not mark it in the form. And then lastly but not least, the discharge will ask for the discharge information of when and where the patient is being discharged or transferred to. Next, we'll go over when to complete the form. So you'll be completing the form when a new patient is admitted who meets the eligibility criteria that I mentioned earlier. And you'll also be completing it when the reason changes. So the primary data gathered by this form relates to the reasons preventing a patient from moving to a different care setting for the behavioral health issues. So it is important that you only endorse one primary reason per entry. And if a patient moves from one reason to another, we ask you to complete a new form and designate the start and end dates that pertain to that new reason. So I'll provide an example. If a patient is ready to be discharged on September 3rd, and they remain in your care until September 5th because they're still waiting for a core service agency social worker in their county to find them a state psychiatric hospital bed, you'll fill out a form and indicate the reason as waiting for CSA inside county of responsibility to identify and make referral as a primary reason for the delay from the 3rd to the 5th. And if on the 5th, the social worker finds a bed, but there is like a waiting list at the facility until the 16th, you'll complete a new entry for that patient using the same ID number that was assigned to the patient and indicate the reason as a lack of space in the preferred setting as the primary reason for delay from the 5th to the 16th. So that was an example of when you'll be inputting, updating the discharge delays. And then lastly, you'll be completing the form when the patient is being discharged. So you submit a new form when a patient is discharged for the behavioral health care at the hospital. And even if patient is like transitioned into a medical bed at your hospital, we do want to track that they're no longer in inpatient care or in the ED for their behavioral health needs. And once you indicate that the patient is being discharged, this will close out the case for the purposes of this study. Okay, so now I'll provide like a quick demonstration of the online tool for the ED for how to enter in data for a new patient with discharge delay. As Kristen mentioned before, the inpatient and the ED tool are very similar, so this can apply to both. Go ahead and share my screen. Okay, can everybody see my screen for the discharge delay?
Yes.
Okay, sounds good. I will just go back to it. Okay, so once you enter the tool, it'll bring you up to this landing page asking you for two options, either to start a new form for a new patient or accessing a patient that you've already started. For the purposes of the demonstration, we'll go ahead and start a new form for a new patient. Go ahead and continue. And it'll take you to a new slide. And this is the randomly assigned number to this patient. Please document this ID number for this patient in a safe space so that you're able to access it to update the patient of any discharge delays in the future. And also in a place where people who are not associated with the study cannot access it. So we'll make a note of that and we'll continue. So from there, it'll bring you to the main menu. And it'll ask you to indicate information you'd like to enter for the patient, and you'll see the ID number reiterated here. It'll have 5 different options for you to enter information about the patient, enter or update reason for their delayed discharge or transfer, the discharge information if you're ready to close out this patient's file, or just move on to enter in a new or different patient. So for all patients, we'll ask you to enter information about the patient, asking you to complete that first. We'll go ahead and continue. I'll ask you to select the name of your hospital. I'll ask if the patient is a Minnesota resident and for the zip code. So let's say yes and zip code of. And we're asking for both of these items because they do differ in how services are accessed and what's available. So we'll go ahead and continue. It'll go on to ask how the patient arrived in the ED, whether it came through family or self, first responder ambulance, law enforcement, transfer from another ED, crisis team, or other. So let's say the first responder brought them here, and then I'll ask for the insurance coverage at the admission and check that all applies, whether they have Medicare, including if it's pending, private insurance, Medicare, Minnesota Care, including if it's pending, or if they're uninsured. Let's choose Medicare for this. Go ahead and continue. Ask for more demographics, so asking for a patient's age and their gender identity. Move on into race and ethnicity just to be able to select one of those. And then it'll also ask if they need an interpreter at any point during the visit. So if they did require an interpreter and unfortunately they weren't able to get one assigned, still indicate that they did require an interpreter, okay? Okay, we'll move on. And then it'll ask when they are either arrived at the ED or if it's for the inpatient, when they were admitted. So we'll go ahead and select a date and time with this pop-up window. So let's say the 20th at about 8. The 27th at about 8 was when they arrived. And then for the ED, it'll ask, for the ED tool, it'll ask for when the decision for the patient's disposition was determined. And let's say it was determined about a couple hours after they were admitted. And then it will have a note reminder stating that for this study, a delay is defined as starting 4 hours after the disposition was determined in the ED. So we'll go ahead and click and select continue. And from there, it'll move on into selecting the reasons for the discharge delays if they have any at this moment. So when you're filling out this section multiple times for like multiple delays, all the data will remain on the screen as you can see below for you to review or for you to update. So I'll ask you to just go down to the first empty section to create a new discharge entry. So if we're going to take a look at the first reason for the discharge delay, it would ask for a date and a time for this reason when they cannot be discharged, admitted, or transferred. So let's go ahead and choose a date. Let's say the day after about 8 a.m. the next day. And then it'll move on to ask you to choose a reason for the avoidable hours, why the patient cannot be discharged, admitted, or transferred. And we ask to select only one reason from this list below. And there are multiple reasons to assign each reason a unique date. So as I mentioned before, these are the following umbrellas, and Kristen will go in deeper definition with these later on in the presentation. So there are internal staff delays, external social service or government agency delays, lack of space or waitlist in safe setting, inpatient or family delays. And the inpatient and the ED tool are very similar in this list. There are some differences noted. So let's indicate that there is a transportation delay and move on from there. The next question is asking if they had any characteristics that contributed to this delay. Um, let's say they had a traumatic brain injury. So if they did have any of these characteristics but it did not contribute to the delay, please don't indicate it here. Um, and then move on to asking for the end date for when they cannot be discharged, admitted, or transferred. So for this reason alone, um, let's if you don't select one, it does pop up a red note saying asking you to enter it in, or just make it just give you a note that later on you should put in a date. So how about let's say that they are not ready to be discharged yet for this reason. We'll go ahead and click that they are not ready for discharge. Will be sent to a comment section and then back to the main menu. So go ahead and click. Oh, they're not ready to be discharged. Actually, let's indicate a date on that. Okay, so we'll go ahead and click continue. Okay, so let's see why it's not going. Okay, so it'll bring you to this asking for any additional context that you might think will be helpful in understanding the patient's experience. And go ahead and click continue. And we'll go back to the main menu. So if you have to go back into this patient's account to change or to update their reason for the delayed discharge, please make a note of their ID number and go ahead and enter in go ahead and choose this option to update their delayed discharge. And as I mentioned earlier, you'll continue to see the first reason here, excuse me. And then if you scroll down, it'll bring you to the next option to enter in the delayed discharge for number 2. Okay. Let's say that we entered here and we don't think that they do have a second discharge. We'll just go ahead and click back in order to not enter anything and go ahead and discharge the patient. So from here, it'll ask you when the patient was transferred or discharged. Let's say they were discharged just this moment. And then ask for where the patient was transferred or discharged to. And these are the following options, and we'll go in further in depth with them later on. How about let's say that they went to an inpatient sector unit at another hospital. Continue. And from there for the ED, it does ask you for how many total locations of this type of facility did you have to contact to locate this specific bed. And let's say we contact the 3 different types. We'll continue. Any additional contacts? Continue. And then lastly but not least, I'll ask you to confirm if this case is being officially discharged. And once you do discharge this case, they'll be no longer to access this case for any updates. So let's go ahead and discharge. All right, and then go ahead and submit for the record.
Alicia or Nate, will you pull the slides back up, please?
Give me 1 second, please.
All right, thank you. And then, so as you may have noticed, I went through it pretty quickly. And the tool is relatively fast and easy to enter and update information. And most of the information is only needed to be entered in once for a patient, which includes the patient demographic and their characteristics. And then for the discharge delays, only one primary reason should be entered for each entry. So you may have to prioritize the most salient reason for any given period of time. And here are just some tips when entering data into the online tool. So the purpose of the identifier is to link multiple entries for the same patient and to reduce the risk of duplication across the forms. So be sure to document this ID somewhere safe so that you can access it later to update those entries, but that others not involved in the study cannot access it. If you are updating information about a patient already entered in the system, make sure to type in the ID number randomly assigned to them in the beginning. And it is important that you do keep track of the patient ID numbers, as while the research has no way to identify who the ID number belongs to. And another tip is to identify ways to work this data into your daily workflow. So this can include designating one person responsible for reviewing all patient cases at the end of a shift to see if there are any updates needed. It could include logging into each patient's record daily to see if there are updates needed or entering new cases. It could include posting a reminder either on paper or electronically on the devices used for updating the EHRs. In Minnesota, in the previous studies, a lot of the hospitals chose to discuss this during your group case planning or supervision meetings, um, or identify specific triggers in your workflow to update forms, such as like making calls for a referral or like sending out new authorization requests. And then lastly, another tip is if you need to leave the tool for any reason, clicking on the continue button before exiting will save everything you already entered. And when you do re-enter the system with that patient's ID number, to choose the section for the tool in which you left off in order to complete your entry. So for instance, if you left off at question 6, asking about the patient's residence, click on the entering data for a new patient button on the landing page to finish updating that section. And then to maintain privacy and confidentiality, the names and other identifying information about the patient will not be included in the tracking form. We ask that the identification numbers will be used only for the tracking forms within the study and to store those ID numbers separately from the patient information. All right, any questions about the data collection process?
And you can feel free to unmute yourself or enter a question in the chat.
There's a question in the chat if there's a paper form that can be used for data collection and then enter it into the portal.
That's a great question. We do have a paper version of the form available, and certainly you could use that. The one caveat is that because different patients have different numbers of discharge or transfer delay reasons, the form only includes one block for the reason. So you may need to fill out that specific section multiple times or somehow note which reason is associated with which time frame. But definitely, if that works better for your workflow, we want to do whatever works for you. We'll just give it a little bit more time for some questions. Where can you access the paper form? We will make sure that that is sent out along with the protocol. In addition, Alicia and Nate, I know that MDH is developing a web page for this study, and I don't know if you think it would be appropriate to put the form there.
Yeah, we can definitely check on that. I think as long as it's accessible, it should be. If that's the best place for it, we're happy to put it there.
And I guess I'd also like to note that if you do choose to do the paper form option, we would ask that you make sure that all data is entered by the end of the data collection period. So by October 20th. Okay, so the question is, your ED is variable with mental health borders. What if you have no borders during the time you choose, the 2-week window you choose? I can speak to my my opinion, but I would also welcome Alicia and Nathan to weigh in on this. I think that, you know, what we're trying to do is reflect. We know that this is a point in time, and we're trying to reflect what happens during an average point in time for any particular hospital. So if you choose a 2-week window and you do not have any borders during that 2-week window, we would love for you to let us know that, to confirm that with us, so we know that it's not just missing information, but that is reflective of your hospital's experience. Alicia and Nathan, do you have anything to add to that?
I would absolutely confirm that. If you don't have them during a 2-week window, that's awesome. And we just appreciate you picking a 2-week window and you know, being part of the study, and that counts even if you have like no borders or 1 or 2 borders. And anything is helpful.
And it looks like there might be. Okay, I think we're going to move into the definitions for discharge or transfer delays, but we will have another pause for questions, and certainly we're happy to answer questions even after today if they come up. As Mia mentioned, she's available for technical assistance throughout the entire duration of this study. So as Mia showed you, we have a list of potential reasons that patients may experience a discharge or transfer delay, and we try to break those reasons into some categories to make it a little bit easier to navigate. So the first category of reasons that we have is internal staff delays. And so this could be delays in creating or implementing a care plan or execution of doctor's discharge orders. This can be delays with the social work department, with referral paperwork, other staff correspondence, etc. We know that delays happen. We know that staff are incredibly busy, and we know that there may be instances where a patient may meet the criteria for being discharged or transferred, but that is a process in and of itself. And so if there are delays that are under this category, we do not see that as a reflection on your hospital. We just want to know what might be happening and what those delays look like. We also recognize that this could be a reflection of staffing shortages or processes that are in place that are outside of staff control. In addition, we also know that there are certain times of days or days of the week where internal staff delays may be more likely, such as if a patient is there in the middle of the night on a weekend, it may be more difficult for them to get access to the discharge planning that they need. And so certainly all of that would fall under these categories. Oh, I also do want to note that you'll see, as Mia mentioned, there are slight differences between the inpatient and ED tools when it comes to the potential discharge or transfer delay reasons. So you'll notice that there's either a little I or a little E after each of the reasons here. If you see the I, that means that the reason is on the inpatient tool. If you see the E, it means it's on the emergency department tool. If you see both, it means it's on both tools. Okay, the next set of reasons that we have identified are external social service or government agency delays. So these are delays that are caused by waiting for a government agency or an external social service agency outside of your hospital system to take action. And so we want to emphasize that these are when you're waiting for things like a referral or you're waiting for processing. waiting for negotiation on a pay rate or something like that, this doesn't mean that you're waiting for a bed in a particular facility. So here we have waiting for a social service or government agency to identify some different types of placements, an IRTS placement and a child or adult. This category is also where you'll see some delays that we know can happen with some of the systems that are required to move patients. So awaiting a MinChoices process, if somebody is needing to go through the MinChoices process to access resources or services, waiting for CADI approval, or waiting for CADI rate agreement for a particular facility. This is also where you'll see awaiting MA benefit activation, which reactivating lapsed benefits. You'll also see here awaiting insurance authorization for a discharge setting. And that could be for the next level of care, such as residential CD treatment or a necessary home-based service that the patient needs in order to safely be discharged home. It could also include awaiting guardianship approval. So that's awaiting county appointment or decisions regarding guardianship before an appointed guardian can then make a decision about a discharge placement. Also under this big kind of overarching category, you'll see delays due to patient civil commitment. And so this includes, for instance, if a patient is admitted and in the commitment process and they've stabilized and medically they are ready to go home, but they need to finish out their commitment process before they can be discharged or released. Under this category, we did include transportation delays. And that includes an MA transportation or medical transportation delay. But we also recognize that there are other types of transportation delays. So this particular reason could apply a little bit more broadly than this overarching category. So if you have a transportation delay that's associated with, the ability of the placement agency to come and pick up the patient or something like that, we would still include that here. And then we do have this kind of catch-all bucket of other outside social service or government agency delays. And that can include things like child protection, county committees for placements, other decisions that are getting stuck in the county social service workflow. The next big bucket that we have of reasons includes the lack of space or being on a wait list in a safe setting. And so under this category, you'll see a lot of the typical types of places that a patient could be discharged or transferred to. So it includes on the ED side, if a patient is unable to access an inpatient psychiatric bed. It can include if a patient is waiting for a state psychiatric hospital bed. And I do want to pause and note that we recognize that many hospitals don't necessarily even pursue a state psychiatric hospital bed placement, or they do concurrent planning because it is so difficult sometimes to get into a state bed. So we want to ask that you identify the reason that is associated with the ideal placement setting for the patient or the most appropriate placement setting for the patient. So if you were able to place them where you think it is the most appropriate, what setting would that be and where are you waiting for access to, knowing that it could change over the course of a patient's stay with you. This category also includes if a hospital bed is not available for transfer to a medical facility. And again, that could be for if the patient is appropriate for a medical bed, but other specialties won't take the patient, often because of their behavioral health needs. Or the patient is appropriate and needs to transfer to a medical unit who's willing to take them, but there's not a bed available. Also under this category, you'll see that we have waiting for a bed in in Wilmer, in a PRTF, in an IRTS, in a nursing home or memory care facility. And so again, you would endorse these reasons if the facility or type of facility has been identified, the patient has been accepted, but there's a delay in them actually moving into the facility. Under this category, we also include if the patient lacks housing or if the patient lacks secure housing that is necessary to contribute to their recovery. So even if they have some sort of housing, if it's not safe or it's not conducive to them being discharged there, you would endorse that reason. And then a lack of access to outpatient services. So if a patient needs something like partial hospitalization or access to a psychiatric appointment or access to community resources in order for them to safely be discharged home, but those services are not available or there's a wait for those services, you can identify that you're waiting or that their delay is due to a lack of access to outpatient services. Oh, sorry, we have many other locations, types of facilities. The last bucket that we have is patient or family delays. And so under this category, it includes when a patient is not willing to adhere to the care plan or they choosing not to move into the placement setting that you've identified. So overall, this would include when a patient is not cooperating with the necessary paperwork or follow-up, they're declining appropriate testing or assessments, they're delaying taking action that they need to do, such as contacting their insurance company to help facilitate authorization. Or if they're not participating in their overall care plan. So for instance, if a patient is stabilized, but then they start refusing their medications and they're unable to then safely be discharged. This category also includes lack of consent or cooperation by a decision maker, such as a parent or a legal guardian. So similar to the previous category, this is when a legal decision maker is not consenting to or accepting the placement or necessary follow-up required. Or if the patient is willing to be moved to a specific type of facility and their legal guardian is declining that or not willing to allow that to happen. This category also includes if a patient is intended to be discharged home and a guardian or family member is unwilling to take them home or unwilling to commit to the care that they need at home. And then the final category is delay due to patient criminal legal involvement. And this is different than patient civil commitment. So this is due to patient legal criminal involvement that may be affecting their ability to move between facilities. This can include if there are warrants or pending court proceedings. It can include if they're on probation and that limits the options for where they can be placed. It can also include if there are any restrictions based on criminal and legal involvement that's making it difficult for them to be placed in certain types of facilities. So before we pause again for questions, I just want to case studies have come from those previous iterations of this study, and we've been very fortunate that some of the participating hospitals have offered us these examples of real patients that they have encountered and how they have thought about filling out these forms for these patients. All of the names and identified information are different, but I want to recognize that these are reflective of real cases. So the first example that we have is an emergency department case study, and I'm not going to read the whole thing to you, but I am going to highlight a couple of specific things. So today we're going to be talking about Jason, and Jason is admitted to the ED on September 15th at 6 p.m. And so that's when he is first arriving in the ED. At 8:30 p.m., the ED has determined that he should be admitted. Decision was made. If Jason is still there after 12:30 a.m. on the 16th, that's when the clock would start for discharge delay and when we would want a form entered for Jason. So in this particular case, he is transferred to an inpatient unit the next morning, but it happens at 8 a.m. So that time period between 12:30 a.m. when that clock starts and 8 a.m. when he's actually transferred into the inpatient unit, that represents a discharge delay. So we would ask that the hospital enter a case and attribute that discharge delay to the lack of bed space in the inpatient unit. So Jason is inpatient for 18 days, and then he's just discharged home with his father. That will close out that specific case for Jason, as Bea mentioned. So he would, the discharge portion of the form would be filled out. It would say that he is discharged home, and then that particular ID number would be closed. As you can see here, on October 14th, Jason has an incident in a grocery store and is brought back to the ED. So even though it's the same patient, which is important for Jason and his family and important for your hospital, for our study, we are tracking delays, not patients. And so you would enter a new form for Jason when he comes back, and he would get a new ID number for the purposes of this study. And so here, he's brought in by law enforcement at 11 a.m. on October 15th. At 3:30 p.m., the team determined that he should be referred to a specialized inpatient unit at another hospital. So that 3:30 is when that disposition decision was made. At 4:30 p.m., the specialized unit approves the referral, but informs the ED that they do not have capacity and they put him on a wait list. So 4:30 is still within that 4-hour time frame from when the disposition decision was made. However, he then, this barrier to a discharge does last longer than that 4-hour window. So on the 15th at 3 p.m., ED staff decide that that particular placement just isn't going to work for Jason. The wait list is too long. So that period of time from 7:30 p.m. on the 14th, so 4 hours after the disposition decision is made, to 3 p.m. on the 15th, the reason would be that they are waiting for a bed in a specialized inpatient unit, so waiting for a bed in an inpatient psychiatric unit. At 3 p.m., they changed their mind about the most appropriate placement for Jason given the circumstances, and so a new reason would be entered starting at 3 p.m. They try to make arrangements for Jason to return home for supports. So now the place that they're hoping to pursue is home. During the stay, the ED had the impression that Jason's family was not giving him his medication at home, and they started to pursue guardianship for if he enters the ER in the future. In the meantime, the family or the ED is working with Jason's family to discuss the importance of medication management and then on the 17th. So in this particular case, although we are pursuing guardianship, that is not one of the reasons for his discharge delay because it doesn't affect where he's ultimately discharged to. So in this case, you would have a second reason because you are working closely with the family to try to get them bought into doing medication management and the need for follow-up. And so from October 15th at 3 p.m. to October 17th at 1 p.m., the reason would be lack of cooperation of the parent or guardian. And I will pause for questions after I go through this case, the second case study. So now we're going to turn to the inpatient side. So in this particular case, now we have Sarah, who is 16 years old, so she is a minor. And in this particular case, Sarah has a history of self-harm and suicidal ideation and attempt. And so she has an incident where she does harm herself, and she does ask her mother to bring her to the ED. So she receives medical care and is getting stabilized in the ED, which is appropriate. Here you can see that the ED arranged for her to be discharged on September 21st. So that's when, or I'm sorry, the inpatient care arranged for her to be discharged on September 21st. So that's when the clock would start if they're not able to find a setting or a placement for her. Just prior to the discharge, Sarah and her mother got into an argument, and her mother declined taking her home, which was the plan that they had in place. So at that point in time, the reason would be a lack of parent cooperation. They tried to find a placement setting with other family, and they were unable to do so. On September 28th, the staff started pursuing a foster care placement for Sarah. So 1 week later, a foster care placement was identified. And then the following week, Sarah is placed in her foster home. So on September 28th, the reason for a discharge delay would change to waiting for a foster care placement. And then 1 week after that, the reason, because the placement was found and then they had to wait for it to open up, the reason would change to waiting for a foster care bed. And then ultimately, Sarah would be discharged into the foster care placement. Okay, I'm gonna take a pause and address some of the questions that I saw coming in the chat.
Yep, the first question, Kristen, was kind of related to the previous one, when we were talking about kind of the nuts and bolts. When they start their 2-week window, do you want them to put information on people who have been there? So people who came into the ED with delays before the window, or only patients who come in during the window and then have a delay?
Yes, that is such a great question, and I appreciate you asking it. We would like you to enter any patient that is currently on a delay when your 2-week window starts. So even if they were admitted, or if they arrived in your ED and had a disposition decision prior to your 2-week window, we would like you to include them if possible.
And the next question was about using the same ID number for a patient who had delays in the ED and then again when inpatient. So sort of that first example with Jason,
Yeah.
where he was in the ED and then went to the inpatient, and then if there was a delay in the inpatient, would he get 2 different IDs or have the same ID, and just noting that that might become difficult in their particular setting?
I can imagine, yes. Yes, so we are treating the ED and inpatient sides of the study separately. We are excited that many of the same hospitals are going to be participating in both sides of the study, but the ID number will not carry over between the ED side and the inpatient side. We also recognize that there are patients who have a delay in the ED and then do not have a delay in the inpatient side, so we don't want to assume that a patient will experience a delay in both. Are there other questions? Okay, well, we just have one more topic to briefly cover. So after all of this rich information is gathered, we will also be asking for one more piece of information from all of you, and that is we will be asking you for a census of all of the behavioral health patients that were in your care during the 2-week window that you chose. That's going to help us identify what proportion of your patients experienced a delay, and so that's our denominator. And that came from the information session that we held a couple of weeks ago, hospital staff identifying that that would be the easiest approach for them. So once we have all of this rich information, Wilder Research will analyze the results, and we will develop an aggregate report, and that aggregate report will go to MDH for their approval and processing. We believe that MDH is committed to sharing results back with you. So I don't know exactly what that'll look like yet, and maybe Alicia could speak to that a little bit more. But in addition to the aggregate report, we are also available to create hospital-specific data tables if that is of interest to you. So we are not planning to do that for all hospitals because they would only serve your hospital. We're not going to share hospital-specific data with anybody else. But if you think that it would be useful for your hospital or your system to have access to information about your specific ED or inpatient units, we would be happy to run that data for you. Alicia or Nathan, do you have anything to add about the reporting plan?
Yeah, we are absolutely happy to and would like to share results with anyone who is interested, whether it's the report that we get from Wilder or kind of a shorter version. But we definitely want to include you in the results and really appreciate that that Wilder will create those hospital specific tables, and would encourage you to take advantage of that if that will work for your system.
All right, well, that's all of the content that we have for today. Again, we will be sharing the protocol and the paper tools with you. So you will have want to watch it again. Oh, go ahead.
Do for a little while, Kristen.
Yep, we'll stay on for a little bit.
No, I'm saying you froze for a little bit.
Oh no, oh no.
Yeah.
I was just saying that you'll get the written protocols, the recording of this training, and we'll make sure you have access to the paper data collection tools prior to the September 5th launch of the study window. In addition, just to reiterate, Mia is available to provide any technical assistance or answer any questions you have throughout the study. We have gone through this process before, and we know that there is no question that's too small. And we recognize that we're trying to fit complex patient experiences into checkboxes. And we know that there's a lot of nuance. And so if you ever want to troubleshoot or talk through any of that, we're available. So now we're going to just leave a little bit of time for any remaining questions. How
Looks
soon
like
will
we
you?
have-
Yeah. So you can get internal tracking mechanisms built to capture each element. So the tools are not currently accessible, which I know is a requirement for sharing them. And so it'll take us a few days to make that happen. Alicia, I don't know if you have anything to add to this response.
No, but we can definitely, Anna, we can definitely make sure. Obviously, you're in the meeting, so if you will make sure that we can send them to you. They may be ready, available before they're on the website, so we can send them to you. And a question about getting the PowerPoint emailed right away would be helpful, and that we definitely can do.
Great, thank you.
And I just want to say thank you again to everybody who came to the training and for being so engaged and asking great questions. We really appreciate that. And we really appreciate your your interest in the study and hopefully your participation as well.
Yes, thank you so much. I think our team will stay on until 9 if there are any last questions, but otherwise, enjoy the rest of your day.
So looks like it's just us now. So we can stop recording, right? Oh, Nate, did you stop the recording?